I'd like to introduce our esteemed surgical colleagues. Professor André De Hoor, coming all the way from Leuven in Belgium, Dr. Phil Fleshner, and then Dr. Feza Remzi. And one of the things at this conference that we're trying to do more and more, IBD we know is a medical surgical disease. So working with our surgeons, having them integrated into these conferences is extremely important to us. So we hope to continue to grow that in years to come. So with the discussion questions, just to set the preview, the first case is going to be a 27-year-old newly diagnosed severe ileal Crohn's presenting with a phlegmon and a small interloop abscess that's not felt to be radiographically drainable. Do you use medicines or surgery first? Obviously, I'm asking the surgeons. That's an interesting question. Anyway, 30-year-old, second is going to be a 30-year-old Crohn's patient, colon only, no small bowel disease, one small anal tag, otherwise normal anus, but rectum and colon are inflamed, failed biologics. Can you do a pouch in a patient with Crohn's colitis, or is a colectomy and an endoleostomy the only option? And then finally, the 29-year-old Crohn's patient, status post-ileocolonic resection and a side-to-side stapled anastomosis 2 weeks ago, and this won't pin on any of you, so this was done somewhere else and it wasn't done in anybody's institutions in here, but now comes in with a fluid collection and an abscess. Is this recurrence, or is this something that's a leak, and how do we manage that? So getting to the first case on the newly diagnosed Crohn's with severe ileal disease. I guess the question from a surgical perspective, if there's a small abscess, phlegmon, 25 centimeters of ileal Crohn's, no other disease, colon's normal, proximal small bowel is normal, no obvious stricture. Is this a patient that you feel, if this was sent to you, that should go to surgery first, or would you recommend that the gastroenterologist, quote unquote, downgrade the inflammation with biologic therapy? So Feza, we'll start with you, then Phil, and then Andre. So Feza, what would you do?
Thank you for having us. So in a patient like this, I think seeing this patient together with the gastroenterologist is very important, so he or she can get the opinion from both sides. But with the new evidence that we have from Europe that came out with the Lancet, in the past we were a little bit shy about giving the surgery first, but I have become, and I always believed, going with the surgery may benefit this patient with limited disease like the one that you're describing.
So let me ask you, before we get to Phil, do you believe in the concept of being able to downgrade inflammation with biologic therapy? Is that, I mean, that's what we talk about quite a bit. Is that true or not?
I do believe biologics is the way to treat these patients to start with. I mean, it's really coming from a surgeon. I believe that. So, but the critical in this thing, this inner loop abscesses, so a patient already had a penetrated and perforated with an infection that's brewing in there. Yes, you can make an argument, we can get a control of it with an IV antibiotics and see what happens. But in my opinion, with this data out there right now, it's really, there's a better option that this patient may be treated well and get on the biologics afterwards. So inflammation combined with the presence of abscess is the reason that I would like to go for a surgery first.
All right. Phil?
Well, I think either way, this patient needs medication first. This patient needs antibiotics, okay? So let's cool off the local inflammation. In terms of specifically your question, do the biologics reduce the amount of bowel that you remove? That, I think, is voodoo. I don't think there's any evidence, although you guys talk about it in a lot of literature. I think all of us as surgeons say, well, we still pretty much see as a very good correlation with what we thought MR imaging before the biologics were put on board. So medications first, and then, just like was said earlier, you have to have a long-term plan here. What are you planning to do? Are you going to go to biologics, or are you going to treat the patients with medicine, with surgery? And you have to have a discussion with that patient in terms of what to do. But clearly, medications first.
So Andre, do you agree?
I agree on the first part that we certainly should optimize the patient with antibiotics, looking how the patient is, because when you go in for surgery, you want to avoid the stoma and to be able to hook up and make a primary anastomosis. And that you can achieve in most of those patients by giving them a course of antibiotics. Secondly, there are few data on the role of biologicals in this setting. But in some patients it works, actually. Because most of the patients that present like that also have a stricture in up front. So when there is a stricture in an abscess, then there is no gain of giving them biological treatment. Then you need surgery. I guess the jury is still out, and a lot of data will come from a French group, JETED. They just prospectively entered 127 patients with that scenario and give them biologicals. And at 1 year interval, they're going to look what the outcome is, how many patients have recurrent abscesses, how many patients needed urgent surgery. And I guess this will give us some indication. Probably not all, but majority require surgery.
So before we get to, I think Corey may have some questions. For the three of you, and maybe Andre will go reverse order for this. If this patient was on infliximab and azathioprine, and they presented like this and you were taking them to surgery, do you need to stop the biologic and immunomodulator prior to surgery? If so, when?
So normally, routinely, we don't stop the biological treatment. We don't stop the azathioprine. We just would optimize the patient and bring the patient to operating theater and do. We just have a slight increase when we looked in our primary resections in patients who were under biological treatment, a slight increase of local septic complications. But the question is there whether it's due to the biological or rather to the disease itself. And I guess it's more to the disease itself, so we don't stop biologicals.
So in Belgium, you're not scared about treatment prior. You can operate on these patients, and maybe high-dose steroids is different.
It's different than UC, however.
Right, UC, and likely you wouldn't do a one step anyway. No. So Phil, do you agree with that?
Well, we take a little bit of a different tact. And by the way, there was a comment made earlier in this session that why are surgeons afraid? We're not afraid. The reason this is an issue, we're not afraid of most things, but I knew this was going to come up.
See how he's flexing? It's like Hulk is coming out now.
But we're not afraid of this, but this is, the most comparable way to think about it from a GI point of view. If you imagine ileocolic resection being comparable to, let's say, a patient with a cecal cancer, nothing to do with IBD, but they're very different diseases. There's inflammation, there's the effects of immunomodulators, there's the infections of perforations that you don't see when you're going in for a routine right hemicolectomy. So because of that, you try to optimize the field as much as you can. Because if you don't, you're going to end up with an ileostomy, which all of you know is what the patient does not want. That's the most feared complication of this disease that any patient with Crohn's knows about. So the way that we think about it, and Cedars, and this is the way I would think about it, is that I would try to stop the biologics for 4 weeks. In our data, it seems that the levels of the biologic appear to influence surgical morbidity in a dose-dependent fashion in Crohn's disease, not in UC. And therefore, because of that, I would try to get rid of the biologic, at least out of the equation, so I'd stop that for 4 weeks before bringing the patient to surgery.
So the gastroenterologists aren't only vague on certain things. In Belgium, go ahead and keep treatment. Phil, stop therapy. Feza?
Yeah, I think the answer is yes, I do stop it. Let me keep it simple. I do agree with both what has been said, but whether this is a medical drug-related infection or patients are coming late, I think it's a little bit both. But I consider the fact that the majority of the patients, at least in our country, they see, I mean, I haven't touched a simple ileal stricture for the last 1 year. It's retroperitoneal perf, interloop abscesses. So there is some problem here. I think we may be, it's okay for the Crohn's to get complicated, but don't let the Crohn's complication to get further complicated. And that's the latter part that we're seeing. So I do stop the biologics before.
All right, so the non-surgeon amongst us, and Corey, I don't know what he thinks, but I don't think there are enough data to say that you have to stop treatment. I know Phil and Feza are suggesting that. I would favor more Andre. But Corey, maybe some questions from the audience?
Yeah, the first one's for Phil, which is, Phil, why are you so afraid?
He's not afraid.
I am not afraid.
But you would still stop.
Concern. How about concern?
All right,
concern.
Phil, I'll ask you a real question. tell us about how you think about the length of ileal segment involved. And you talked about early surgery versus waiting. At what point do you say, boy, this is a long segment of ileum and maybe we should try medical therapy a bit longer here? What in your mind is the cutoff when you're thinking about these patients and seeing their imaging that helps drive your decision making on, this is a short ileal resection versus this is going to be a bigger deal?
No standard definition. In the Lyric trial, for example, they use 40 centimeters as their cutoff. I think that's a long section. But remember, it's 40 centimeters, not 40 inches. So you have to put that in perspective. It's a very, very different thing. I think you presented the case with 25 centimeters of disease. So it's literally approximately a foot of disease. They have another 19 feet of bowel up there. So presumably they should be okay. There is no standard definition of that. Certainly 3 feet, 4 feet, 60, 70 centimeters. That, I think, try to push the medical therapy as much as you can.
Feza, if this was a short segment here, let's say 5 to 10 centimeters, just tell us about the, not as complicated as some of the patients you just described, but seeing what you're seeing here in this case, what is the post-operative course in this patient that when we're seeing them in the office, we could help them understand what they're in for?
So this is a virgin abdomen. It can be done laparoscopically or it can be done single port. If depending on the tissue qualities, if I excise all the disease, it's unlikely that this patient is going to need a stoma at all. I think it's very important for them to know. But if there's still a good amount of crud and infection and the tissue qualities don't look right, I will not hesitate giving these patients a stoma. I know this is being used for marketing, fear tactics and everything. I want to be very clear on the message here. Giving a stoma respectfully is a surgeon's decision. I have seen my gastroenterology colleagues in the past in the podiums and everything go, if you give a stoma, I send you another surgeon. That's all right. That's okay. But this is something on surgeons' conscience to give them a stoma or not. I'd rather have somebody to be upset to me 3 months rather than 2 years with leak infections and suffering for the rest of their lives.
So how do you really feel, Feza? No. So take-home points. Most patients with penetrating Crohn's will require surgery. I think we all agree if they have a stricture and a fistula proximal, that's definite. If they have a fistula with an abscess, no stricture, we could try to drain and then treat. The timing of surgery depends on complications, stricture, small bowel dilatation. If there's panintestinal, extensive Crohn's disease, and they have a short stricture, it's reasonable to give medical therapy perioperatively, probably to treat that patient very aggressively. And a fibrostenotic stricture with proximal bowel dilation and symptoms of obstruction generally does not respond to medications. So next case, this comes up quite a bit for the gastroenterologist before we send the patient to you as the surgeon. This is a 30-year-old female with Crohn's of the colon, no small bowel disease, one small anal skin tag. Otherwise, the anus is normal. So retroflexion exam, there's no fistula, there's no other disease, there is a small skin tag. The rectum is involved and the colon is involved, and she has failed biologic therapies. Do you do total proctocolectomy in a pouch like you would a patient with ulcerative colitis, or does this require a colectomy with an endoleostomy? So Andre, what would you do in this case?
So first of all, the rule of thumb is, of course, when you have a Crohn's disease of the colon and rectum, you would go for an intrasphincteric proctectomy, coloproctectomy, and an ileostomy. The question is, in this rare occasion where you really have a complete normal anal canal, spared sphincters, no history of fistula, and the patient has never got terminal ileal disease, whether you can consider an ileoanal pouch. There are no long-term data from the French group in Paris from Yves Panis that show that indeed the risk of losing the pouch is increased, but it's still moderate. About 8 out of 10 keep the pouch. So indeed, and especially today with biological treatment available, you probably could consent that patient to undergo pouch surgery and then or immediately start with biological treatment to avoid any flares within the pouch, or to start when flares happened.
So just to pin you down, and then we'll go to Phil and Feza. If you were to do a pouch on this patient, 2-stage, 3-stage, and you already mentioned biologics, when would you be comfortable with the gastroenterologist starting biologics? Is it after the first stage, or are you okay with starting now and then doing the colectomy?
So most of the time, but it's outside Crohn's disease, we give the patient modified two-stage. So what we do is we take out the colon, give an endoileostomy, and then the second stage is giving the patient a pouch. Normally, we ask the patient, the gastroenterologist, to start treatment normally 3 to 4 weeks after surgery, and then they can easily start with biological treatment. In this case setting, of course, you would do it probably in a different way. You probably would go on the safe side and opt for a 3-stage pouch procedure.
Okay, Phil?
Well, what I tend to hear as a surgeon is the following. Let me just give you a practical approach. This young woman comes in, and she says, so let me see if I understand this. You want to give me, the standard of care here is to have, excuse me, a total proctocolectomy and endoileostomy. I'm going to have to live a bag with my rest of my life. I'm going to I'm most likely going to get a peristomal hernia in my life. I'm going to get a bowel obstruction, and I may actually get disease back in the bowel that you're leaving. Okay, that sounds great. Now let me see if I can understand this. You're also telling me that there is a potential, however, that I can have an ileal pouch, where I don't have to have a permanent stoma, no incision, no peristomal hernia, potentially no disease in the proximal bowel, and you're telling me, so what's the incidence of it coming back? We, and actually Feza, have actually published some American data looking at this, and we've actually found that although about 40% of the patients end up back with inflammation, and they can be put on biologics, that the vast majority of them don't end up with the endoileostomy, which they otherwise would have had. So they look at me and they say, so you're going to tell me I have about a 5% chance of needing a permanent ileostomy, albeit with biologics? Sign me up. Now they have to be obviously informed about the potential long-term use of biologics and Crohn's disease, et cetera. But I think that what's really changed about this is the use of biologics. Mm-hmm. The biologics have really changed the paradigm in this. So I would offer the patient an ileal pouch with appropriate counseling.
So Corey, Phil doesn't seem scared anymore. Feza?
I would go
I'm concerned.
I would go for a 3-stage here to confirm that definite diagnosis of Crohn's disease. If the diagnosis comes back for sure a Crohn's disease, I had a heart-to-heart discussion with the patient, and what she thinks really is more important than what I think what should be done. As much as I agree with most of the stuff with my dear friend Phil, I don't think if somebody can live with a permanent ileostomy, trying to convince them to have a J pouch, I think is disservice. If they have an endoileostomy, the chance of Crohn's coming back in that area, yes, some technical surgical things may happen, is around 15%, so it's really small. However, if you hook somebody back up, that chance, despite our really good safety data, is higher than that. If she says, yeah, I'm going to go for the J pouch, since the diagnosis is Crohn's, I like to operate biologics on board at least. And on a patient like this, if I have a concern of a Crohn's disease, I'm more of a staple guy. And hopefully you guys will all come to surgical section tomorrow. That in this setting, I will do a mucosectomy and hands-on to eliminate the disease with a J pouch.
All right. So I think from take-home point, surgeries for colonic Crohn's with severe anal involvement, which is not this case, I think most would agree still requires an ostomy because the anastomosis is going to be nearly impossible. So abscess, stricture, fistula at the anal area. Surgery for colonic Crohn's when there's anal rectal sparing allows for resection and anastomosis. So rectal sparing we didn't talk about, but I assume an ileorectal would be reasonable, or a colorectal if it's a limited resection. The question then becomes pancolonic with rectal involvement and anal sparing. The idea had been, or at least most of us as gastroenterologists felt that this required an endoileostomy. However, you're hearing that a pouch with post-op biologics may be considered in select cases. So let's go to the final case. This is something that we encounter as gastroenterologists, and sometimes we're asked to treat this as Crohn's, and I'm curious to hear, how do you approach this from a surgical perspective? So this is a 29-year-old Crohn's patient who underwent an ileocolonic resection, a side-to-side stapled anastomosis 2 weeks ago at an outside hospital. And I'll mention on the pathology, macroscopically and microscopically, there are clean margins. Now, comes in with a sinus tract and a phlegmon with abscess adjacent to the anastomosis, referred to as Crohn's recurrence and biologic, that doesn't make sense, referred for Crohn's disease recurrence and biologic therapy. So the idea is they were transferred in and said, this is Crohn's disease, we want you to start them on biologic therapy. So Phil, I'll start with you in the middle. You're shaking your head. Is this Crohn's disease? Is this something else? How would you approach this from a surgical standpoint?
Leak. This is leak.
So say that again.
Leak.
All right, we got it.
This is not CD recurrence with clean margins. And quite frankly, the worst thing I think you'd want to do is start biologic therapy in a situation like this. Presumably they have an abscess as well. I think that would be a big mistake in this situation. So this is our problem. I mean, it's all of our problems, but there are some surgeons who, shall we say, are a little defensive at times and cannot account for their surgical morbidity, and they say, oh yeah, this is Crohn's coming back. This is leak, period.
So Andre, if this was somebody you saw, this was referred in, the gastroenterologist is concerned about a leak and they send to you, how do you manage this patient? What do you practically do at this point?
So first of all, we would ask for CT scan to look really what's happening there. And I guess one of the misunderstandings is when you get this CT scan report from radiologists, then they put there, could be a leak, but also could be like recurrence because they see like an inflamed loop hanging there or some clusters of loops. So now, normally, after 2 weeks, you lost your window of opportunity in most of the patients that you can immediately go in again. So now you need to gain time, and you gain time by again, looking whether the patient can be fed adequately enterally. You need to give antibiotics. You need to drain the abscess if it's drainable. And you really need to wait. And most of them will not heal. And in most of those patients will need to have a redo anastomosis. But routinely, we wait for 3 to 4 months if it's feasible.
So you wait 3 to 4 months just from a gastroenterology standpoint, because we may not understand. When you say you lost the window to reoperate within that 2 weeks, why is that?
So normally, when you have an immediate postoperative complication or a very early leak, there's still like in the first week after surgery, you still can access the abdomen, especially when the patient has got a laparoscopic approach, and try to re-resect, hook up, give the patient a stoma or so on. But after 10 days or 2 weeks normally, you get like a fused or a hostile abdomen. If you would embark on surgery, then you're going to make things worse. You can end up with a lot of enterotomies, and so we routinely then wait.
We teach our residents and fellows that it's the 6 days, 6 week rule.
Yeah.
Basically, you don't operate in between that window, okay, unless you have to.
So I like the surgical terminology of hostile abdomen. So Feza, when would the time be that you would say this is Crohn's, not a leak? So say this was 2 months later, 6 months later. At what point would you say, yeah, this is early Crohn's recurrence?
So this is one thing, just to expand on that, I call this the checking your own footsteps and leaving your ego at the door. And oh my God, I have seen enough egos as a surgeon. But honestly, God, you got to leave your ego at the door, and you got to believe the fact that this is your complication. So, in my opinion, anything within 6 months to 9 months after a surgery is related to surgery rather than the Crohn's, and to get something that patient really was absolutely great, and they got this type of a recurrence, which is an infectious complication within 6 months to 9 months, is incredibly rare. So this is very surgical. And one other thing that I just want to expand on that, I try to teach, I don't want the people to get the impression any patient comes under my care gets a stoma, but a liberal diversion is a sign of maturity as a surgeon. I just want to make sure that message is clear.
So you said...
I never make stomas. I never make stomas, Feza, by the way.
Check your ego at the door, and Phil, you need to be more mature. So let's end with some take-home points, and maybe the three of you can comment on the timing between leak and when it's a post-op recurrence. So the timing of post-op phlegmon and abscess often determines a surgical leak from Crohn's disease. I think probably most would say within 30 days, most likely an anastomotic leak if there's clean margins on the path. 1 year or more is most likely recurrent Crohn's. I think probably everybody agrees. And then it really depends in between, and I think the timing could be debated. Andre, I don't know if it looks like you were about to say something. Since you're the guest speaker internationally, I'll give you the final word before we wrap up the session.
So today, quite a number of patients are scoped at 4 months or 6 months interval. And in a subgroup of patients, you already see quite extensive disease recurrence. So although it's not at 1 year, you already can have quite important disease recurrence, not at all linked with postoperative complication at 4 months interval.
Great. Well, I want to thank our surgical panel. Thanks, everybody, for a great morning. Enjoy your lunch and enjoy the afternoon.
That's good.